So, good evening, everyone. Can you hear me?
Yes.
Yes.
Oh, okay. So, thank you, Dr. Khalid, for the introduction. والبقاء لله ما أخذ وله ما أعطى وكل شيء عنده بقدر. So, my talk today is about non-invasive ventilation in delivery room. So I have been here in Cleveland Clinic almost 5 years, and this is the NICU and the main campus at Cleveland Clinic will be somewhere in this place here. And I will share with you some of the experiences that we achieved in Washington and in the Cleveland Clinic as well. So we have 87 beds with 10,000 deliveries, and of course it includes all subspecialties and all surgical subspecialties as well. When I start my work back in 1997 in Washington, D.C., you can see the use of CPAP was very low. And after being the director of the George Washington University Hospital, the use of CPAP increased significantly. And that was associated with a significant decrease of BBD. That is one of the lowest reported in the nation, or you can call it in the world as well. It's around 5% instance of chronic lung disease in infants less than 1,500 grams. And that was not only for a few years. Actually, I just recently in 2020 report the experience over 16 years. And you can see it has been very consistent instance of chronic lung disease that was 7.6 after the implementation of the non-invasive, the bubble CPAP system, and go all the way down to 5%. And the survival of these babies around 83.8%, and there were 10% of babies who had surgical or transport. This is 3 years experience at Cleveland Clinic. You can see the incidence of chronic lung disease at the start of my work in 2017 was around 44%, and also were able to bring it down all the way down. It's currently around the same number, 5 or 6%. So why I'm bringing these numbers? Because many times we hear too many beautiful talks about ventilation and support that is of basically literature research and more hypothetical talk. But here I'm bringing to you an experience, and using that experience at the bedside, you will receive the outcome that you like to get. So my presentation today is a presentation that is backed up with a clear outcome you can see over here. So when you talk about delivery room, I would like to touch base what to prepare before delivery. You called for a delivery for a 26-weeker or 27-weeker. Before I go to delivery room, what should I have prepared? And then in the delivery room itself, I have to use oxygen, positive pressure ventilation, and then if there's intubation, surfactant, non-invasive ventilation. So these are the options. And then how fast should we move from the delivery room to the NICU? So basically, we need to have a bubble CPAP system. So when I receive the call in the delivery room, before I move to delivery room, I will inform the respiratory therapist, get the bubble CPAP ready at the bedside in the NICU before even going there. We don't know if the baby might need bubble CPAP or might be intubated. It's okay. You can put a ventilator at the bedside as well. But the point is, when I take the baby from the delivery room to the NICU, there is no time for the lungs to wait for getting a CPAP system ready. You talk about seconds, the lung will collapse. So really, if you really would like to have a successful system, you need to have everything ready. So the 27-weeker, I don't know what size Prongs would be. Most probably will be size 0, but maybe a baby will be bigger. Then get the 2 Prongs ready, size 0 and size 1. I'm talking about the Hudson Prongs, or for the Baby Plus Prongs, that these are the ones that we're using. So when you look to the fetus, start from the 1 cell and 2 cell and morula and this kind of the embryology, then you move forward. If you look to this red bar, the red bar presents the anatomy, and you can see the heart is completely formed by 6 weeks, and you can see different lower limbs and upper limbs, and different systems are made the red bars. But beyond the red bars, this is the yellow bars that presenting the development of the physiology. So the preparation or the cooking for having a baby who will be diabetic, it occurs in this area. Having a baby who will be asthmatic will happen in this time. A baby who will have allergy in this time. Even cancers, and that's what we call the epigenetic time, happen around that time. And this is when you are attending a delivery of a premature baby after 20 weeks. This is the time the baby is programmed. So the very first hour of life is so important in programming the entire life. That is not as much important as when the baby spent 8 weeks in the NICU, for example. And this is a study, for example, was published in Pediatrics by Maximo Vento from Spain, when he randomly assigned full-term babies, randomly assigned to 3 groups. There is a control group who are healthy newborn infants and did not require any resuscitation. And this a group, 2 groups here that required some resuscitation with bag and mask ventilation. So there are some babies get bag and mask ventilated with room air, and we'll call this room air resuscitation, RAR. And a group of babies that resuscitated with 100% oxygen resuscitation. And then when you measured the antioxidant system in the baby, that include the glutathione, the superoxide dismutase, and the catalase, and you can see at birth the ones who were stressed and required some bagging with room air or with oxygen, compared to the control group, they have a decreased glutathione and catalase and superoxide dismutase in their system. That is understandable because of stress. But what is not understandable is that after 3 days, the antioxidant level is still low. At 28 days, babies who received oxygen, they are still depleted of antioxidant for 28 days. And the exposure to oxygen in full-term babies in this study had a median of 7 minutes. So full-term babies exposed to oxygen for 7 minutes are depleted from antioxidant for a full month. And of course, We don't know what happened after 3 months or after 1 year, because the study stopped at 28 days. So we don't know for how long oxygen exposure. The same group have conducted another randomized clinical trial in premature babies. And you may be aware, premature babies, when you start them with resuscitation in delivery room, so they divided the baby randomly into a group of babies. Will start them on 100% oxygen and wean with a blender to achieve the goal saturation according to NRP. And other groups start at 30% oxygen and increase FiO2 to achieve the goal set. So basically, they both arrived to the goal set within few minutes, but the exception is that one group were over-oxygenated for a couple of minutes, and the other group were under-oxygenated for a couple of minutes. And believe it or not, the study showed that the group that started on 100% oxygen have a significantly increased incidence of BBD later in life. So really, you didn't need more than a couple of minutes of hyperoxygenation in the NICU to increase your BBD. And that's why we used to use a blender even before the NRP recommendation way long ago, because oxygen is a toxin and is injurious to the lung. Look at these two studies that came from Sweden, looking to 578 children with lymphatic leukemia. They found that retrospectively go to their delivery room resuscitation. They compared to a control children who did not have leukemia. They found that the children with leukemia were more likely to be resuscitated with 100% oxygen. So the odds ratio to have leukemia when you are resuscitating with 100% oxygen is 2.57. So basically, if you have twin babies, one you put him on 100% and the other not, so the chance for one baby increased by 2.5 folds, almost 3 folds increased risk. You triple the risk for leukemia by exposing the baby to oxygen for a few minutes in the delivery room. Then they looked to not just oxygen. How about oxygen that continued beyond 3 minutes? So if the oxygen was 1 or 2 minutes, yes, it will increase the risk for leukemia by 2.5 times. But for 3 minutes or more, the risk becomes 3.5 folds. And then another study looking to all type of cancers, not just leukemia, for exposure to oxygen more than 3 minutes, again, increased risk for childhood cancer as well. I have to tell you, there are other studies that did not find such association, but these two studies came both from Sweden. They have a very strong association of use of oxygen, and that is the programming. So have to be very careful about the use of oxygen, not just for the cancer, but for the health of the lungs of the babies that you are resuscitating. How about positive pressure ventilation? You get the baby, you give the baby a few bagging first, and you also know that this is, I just will offer you one study that were done in premature lambs. And the premature lambs, and interesting, the study was done in Sweden as well. And premature lambs, they have it randomly assigned to two groups. One group would get 6 types of bagging using extra volume or extra pressure. And look here, this is the compliance curve. Pressure, again, is volume, that is the compliance. So you can see the pressure, again, is volume. The compliance, as you can see, is very low before giving surfactant. Then after giving surfactant, 45 minutes, the surfactant has increased the compliance, then 75 minutes, and then after 4 hours, the compliance is 30 cc's of air of volume with a pressure of 30. But the experimental group that get the extra bagging, the extra volume bagging before surfactant, after surfactant, the volume is only 10 compared to 30. So basically you cut the compliance of the lung to 1/3 just by giving 6 aggressive bagging in the delivery room. And here with the large aggressive bagging, with the normal bagging, and you can look, here is the small low power and high power. You see with the normal bagging how the alveoli and the septation, very nice looking alveoli. And here you start to see the alveoli actually getting some collapse and less air spaces, as you can see. So many times we claim, oh, the baby has surfactant deficiency, that's why he has bad BBD. We don't claim, oh, this baby received bagging for significant time with aggressive bagging, or this baby was on high oxygen in the delivery room for a long time because we did not have a pulse oximeter, or we did not attach the pulse oximeter to the baby's hand in the delivery room. Just these tiny things will make a huge difference in the baby's performance in the NICU. This is not a study. This is one of our babies that we called, the baby was actually 32 weeker, who was in 30% oxygen hood. And then the transport team went to pick the baby, intubated, start bagging. And by the time the baby arrived, was arrived by hand bagging for 20 minutes. And you can see the flat diaphragm and the hyperextended lung, severe PIE. Baby now is requiring 100% oxygen. Baby died on the same day of arrival. Just by hand bagging, you can kill a baby. Delivery room is another problem in the delivery room. IVH, we know that IVH in very low birth weight infants is a major problem, is associated with handicapping. And I looked to around 342 babies to look to instance of IVH in my population. Was one highly associated with IVH with the birth weight, the younger birth weight or the younger age or smaller birth weight, and then delivery room intubation. Delivery room intubation increase the instance of IVH odds ratio 2.7. You almost triple the instance of IVH when you are intubating a baby in the delivery room. And again, you see, I published this in 2011, 2016 came another article for babies who are anyway intubated. If you intubate for the first trial versus you need 2 trials to intubate a baby or 3 trials, they found that for each extra trial, the odds ratio for IVH, intraventricular hemorrhage, odds ratio is 1.317. Basically, 32% increased risk for IVH with each additional trial in the delivery room. And specifically for babies less than 750 grams, it's not only the delivery room, it is the first 4 days of life. Each extra intubation trial is associated with 40%, 39.5% increased risk for intraventricular hemorrhage. So when we are intubating a baby, quote unquote, electively to give surfactant, you are imposing risk for handicap to this baby for IVH. We look to neurodevelopmental outcome in very low birth weight infant, and of course, the worst neurodevelopmental outcome was associated with in babies who were intubated in the delivery room. Again, this is the 342 babies that I followed for 9 to 18 months. The ones who were intubated in the delivery room, 45% of them had adverse neurodevelopmental outcome, and the ones who were not intubated in the delivery room, only 16% were not 16% had neurodevelopmental outcome delay. But surfactant is important, don't you agree? Just give me 1 second, please. So yes, surfactant, you look to this study for ensure, looking to babies who are on CPAP and see if I give surfactant, will I improve the failure rate? And the study showed that with surfactant, failure rate will decrease from 60 down to 50% for babies who are 29 to 36 weeks. The problem here, and I would like to visit this area, when we are looking to a study, we are very biased towards looking, oh, it's a randomized controlled trial. That's level 1A evidence-based. So please don't get fooled with the methodology and focus on the results. This study that showed 60% of babies who are 35 weaker or 29 to 35 weaker fail CPAP and are intubated. What is your failure rate for a 32 or 33 weaker on CPAP in your NICU? If your failure rate is 60%, you intubate 60% of your babies, then give surfactant. My failure rate with a bubble CPAP experience for babies less than 1500 grams does not reach 10%. So should I intubate the baby, give the baby surfactant when I have only 10% failing? This is another study, randomized again, randomized control trial for babies, very low birth weight infants. And when you ensure the baby gives surfactant before starting CPAP, they significantly decrease BBD from 59 to 49. So successfully, they decrease the instance of chronic lung disease to 49%, to 50%. And I just showed you my experience. I have a 5% instance of BBD in my population without insure to babies. So really, the key here is really you need to train at the bedside and make sure that you have appropriate skilled people to have a low BBD, rather than you need to keep adding one medication after the other. So if you talk about the evidence-based medicine, for even when you do meta-analysis of all of these trials, randomized control, really giving surfactant does not decrease BBD. Giving surfactant improves survival, which I fully agree. There are some babies who would die, and these babies, by the way, everyone will intubate these babies because they are very viable babies who will die. So these babies, I will give them surfactant because these babies, I intubate them anyway. But you give me a baby who is spontaneously breathing, who's kicking and crying, and then you put a scope in the baby and you intubate the baby, and then he become depressed and he got IVH to give him surfactant, and maybe by the time during you're giving surfactant, you're going to give a couple of extra bags. And I showed you that bagging will cause damage to the lung, and you don't need more than 6 types of bagging. Then someone else will, well, let me do the mist. Minimally invasive surfactant therapy. Basically, you are having the baby on CPAP, but then you go with the scope and you put a catheter so that this way you are not doing the bagging, but you are doing the scoping. If you believe the scoping is critical in causing IVH, then you are causing IVH. But the meta-analysis of 30 trials that included around 6,000 babies, 5598 babies, between 25 and 32 babies, they found that mist was associated with better outcome, death, and BBD. Mist was not associated with decreased BBD. It was associated with decreased both combined death and BBD. So really, if you think the baby will die, definitely give surfactant. And by the way, he will need intubation anyway. How often you have a baby who's in CPAP who will die right away? I mean, they go through so basically they will go through a process and they'll be intubated or in the ventilator. And then during the 30 trial, when they did the meta-analysis, the BBD average in this group is 33%. The combined BBD and this with 33, and BBD is 26%. So if you have a BBD of 26% or higher, possibly giving mist will improve your death and BBD. But if you have a BBD of 5 or 6 or 10%, then mist really, that's not a problem. I mean, not adding any significant improvement. The Canadian Pediatric Society guidelines just came last year in February 2021. They are recommending to give surfactant, which is I agree with, if the FiO2 is more than 50%. So when I start babies on CPAP, if a baby requires 50%, I will give surfactant definitely. You give it by Ensure, you give it by mist, you intubate and put the baby on the vent, but the baby needs surfactant definitely. And more than likely, this baby will fail CPAP. More than likely, this baby will need intubation anyway. So give it as soon as you can when you have a 50%. But give him some time first. So baby immediately after birth, he might need 80% oxygen. But within half an hour or 1 hour, I see the FiO2 coming down to 25%. If the baby's FiO2 sustained at 50 or higher, I think we should intubate this baby and give him the surfactant. Also, the Canadian Pediatric Society, they say mist can be used in a CPAP-supported infant if feasible, meaning that if you have the experience and you have the tools to do that. I mean, we don't want to experiment on babies. The problem, these babies are the most fragile babies we're talking about. We're not talking about a 2-kilo baby. You're talking about a 500 and 600 gram baby. And if you do any error, the baby will rupture a vessel in the head and have an IVH. He's handicapped for life. So we have to be very careful about that. So now we agreed that you really would like to provide a respiratory support that go more towards a non-invasive, because invasive, we just indicated that intubation is associated with IVH and ventilation is associated with chronic lung disease, and that is known. Then what type of non-invasive ventilation? So there are so many. CPAP, nasal cannula, high flow nasal cannula, NIPBV, synchronized NIPBV, and then the CPAP. Within the CPAP, there is RAM cannula, which I fully disagree that RAM cannula is a source of CPAP. See, the RAM cannula is a cannula, it's not CPAP. And then ventilator CPAP, and then the bubble CPAP. So I just would like to go over this trial, the HIPSTAR trial, for early high flow nasal cannula, multi-center randomized control trial for babies who are 28 weeks or greater. They were assigned to 2 groups. One group, they put them on high flow nasal cannula. The other group, they put them in CPAP. They call it CPAP group. And they look to the treatment failure within 72 hours. So treatment failure within 72 hours was 25.5% on the high flow nasal cannula, 13%, exactly half rate for failure rate. And then when they divide it by less than 32 or more than 32, you can always see half the 33 versus 18. So the conclusion of the trial is that high flow nasal cannula is an inferior therapy. Then the group did another trial called the Hunter trial. Again, the same story, but now for bigger baby, 31 week or greater. Failure rate for high flow nasal cannula versus for CPAP. And you can see that the failure rate was high flow nasal cannula was 20.5 versus 10.2, exactly double the rate of failure. So the conclusion from the trials, when used as a primary support preterm with respiratory distress, high flow therapy resulted in a significantly higher rate of treatment failure than did CPAP. So really, we are now in the era of evidence-based medicine, but unfortunately, people are so selective in choosing the evidence-based medicine. Like, for example, what is the evidence that you use or that you have to ever use any high flow nasal cannula in the NICU? So the answer is zero. There is not a single study in the globe, in the world, that showed high flow nasal cannula can do any good thing to any baby. Any. However, it's most commonly used in all NICUs. Just it's easy to use. And it's non-evidence based. But you start to say, let's use CPAP. Then you say, what is the evidence? Before you say that, then what is the evidence of using high flow nasal cannula? So the answer is no evidence. If in fact, there is evidence showing that high flow nasal cannula is associated with worse outcomes. So when I talk about the CPAP, Dr. Jen Wang at Columbia University started the CPAP. This is the type of CPAP that we are using because not all devices are the same. So we use the one that has a Prongs that can be stabilized and attached to both sides and really fit snugly inside the nose so that really the pressure arrives. By the way, RAM cannula, if you have a RAM cannula in your NICU, by the FDA, when it got approved by the FDA, it has to have 50% of the nasal cavity should be around empty, meaning that by definition, when you are using RAM cannula, you should leave a big leak around it. So you are not really providing pressure. Or if you are really making snugly RAM cannula into the nose, then you are using it outside of the FDA approval. That is kind of unsafe practice because you are taking a device, are using it outside of the FDA approved it with a condition that you put a RAM cannula in the baby's nose, you have to leave 50% of the nose empty. So that meaning that if you really have a snuggie, the pressure can be very high and can be injurious to the nose. So what type of CPAP? Only public CPAP. And there are very specific technique on how to do it. We put a duoderm on the nose or what you call cannulate with two tiny holes. Then we'll have the CPAP prongs. We'll put a Velcro around it, put a Velcro on top of the mustache here, and then attach to the nose. Always leave a space. The details of that in procedural neonatology book that I have a chapter on that. And then we'll have a checklist for every specific piece, such as, do you have a big neck roll underneath the baby's neck? Do you close the mouth with a chin strap? Do you have an OG tube to suction the stomach air? Do you have a snuggie head cap, tube to the side, leaving a space, booking the right Bronx size? Then really you will have a good outcome when you're applying the right CPAP there. So, and I like this phrase that I read it for Bruce Lee. He was saying, I'm not afraid of a person who knows 10,000 kicks, but I'm afraid of a person who knows one kick, but practice it for 10,000 times. You go inside the NICU, you find that 10,000 type of devices you have, ventilators and CPAP and CPAP and neck cannula and all of that. Really, you need to have a one device, which I recommend the bubble CPAP, but make sure you practice very well and you have a bedside skills, then that time you'll have the best outcome. So to conclude, for the delivery room management, make sure you have oxygen blender in the delivery room. Start it at 25, 21% if a full term, and 30% if less than or equal 30 weeker. So I use 30% for 30 weeker or less. Positive pressure ventilation. It can be injurious to the lung. Always use the T-piece or what we call it the NeoPuff or whatever apparatus you have to minimize the use of unmeasured pressure when you are minimize the use of resuscitation bags. Once you establish good heart rate, more than 100, do not rush to intubate. What is the purpose? So many times, trust me, many times, you have a baby that you start bagging or you start the baby on a NeoPuff and heart rate picked up, but the baby doesn't want to breathe. Just give him 1 or 2 more minutes. 1 or 2 more minutes. He will pick up and he will cry. Rather than you advance, you intubate, and then the first question will be when to extubate. Once an infant starts spontaneously breathe and having a heart rate more than 100, rush to the NICU where it's more controlled environment. Don't stay too long in the delivery room. Get the baby as soon as possible. Once you have a good heart rate, take the baby out to the NICU. There is no evidence to support efficacy of high flow nasal cannula. NICU is the lowest instance of BBD. They are using bubble CPAP exclusively, one device only. Bubble CPAP success depends on the bedside skill. If not, it is not the device, it is the operator training and skills. CPAP setup is always ready in the NICU before delivery. CPAP is applied in the delivery room via the T-piece, the NeoPuff, free flow system. Premature infants are transferred to the NICU and immediately started on CPAP. And finally, intubation is associated with IVH and potential handicaps. Therefore, surfactant is administered only if the infant is clinically requires intubation or high flow or high amount of oxygen. I define it as 50 to 50% or more. And thank you very much.
Thank you very much, Dr. Hany. Really fascinating presentation, and it is practical to the point.